So yes, well, thank you very much for the opportunity to speak here to you about, well, what I would call my fascination for learning health systems and the use of health data, which started in the year 2002 when I became at Nivel project leader of the national, what is it called? Nivel Primary Care Database. And that period started in 2002. I started leading that project and solving all kinds of problems associated with data. The governance issues, who is allowed to do what with the data that we collect. The data quality issues, how do we improve the quality of the data? And I learned quality of the data is not a good term for that. We need to use other terms. We better use fitness for purpose of the data. And all the time I was doing things that were related to learning health systems. Only I didn't know that word yet. That term came later. And about in the year 2010, there was a project that I participated in which I learned about learning health systems. And what I had actually been doing is building learning health systems and solving all the problems in these learning health systems. And after 15 years of solving all those problems, I thought I had enough of that. I don't want to solve the problems anymore. I want to look at it in a different way. And I started a research group in Nivel, making research into, well, the development of learning health systems, the facilitators, the barriers, how can you promote learning health systems. And this also relates to one of the comments that was made earlier today, that you have to Ellen said that we have to take an interest in the intermediate things, the meta things of the research that we are doing. And that in itself is a really, really, really interesting field of research. And I want to tell you a little bit more about that in my presentation, which is titled Developing Learning Health Systems, Is Fair the Chicken or the Egg? And yeah, well, we have been talking about learning health systems and fair data, and then I wanted to ask you, so we're sitting there. Yeah, please.
Numbers were phony, just like they were before the election, and there were other times. So you know what I did? I fired her. Right. And you know what? I did the right thing.
I did the right thing. So the question then is, whose right thing are we talking about? I think doing the right thing is a very, very, very important element in any learning health system. But whose right thing are we talking about? And I think the person that was fired had all kinds of high hopes and high thoughts of fair data. She had been working on that all her life. And then this guy came and fired her. And, well, that is start of a fascination of mine that started, well, I think a couple of years ago, and made me read this little book again. It is called Wetenschap als beroep en Politiek als beroep, written by Max Weber, sociology or a philosopher in the beginning of the 20th century. And this is an essay that he presented on for students in 1917. And 1917, you may know that from your history classes, was the time where the world was at war with each other. So there were turbulent times, and I thought this is going to give the answer. Well, I started a conversation through ChatGPT with Max Weber, asking him all kinds of things about learning health systems. which was very interesting, but I'm going to talk about that later next week. We also have a meeting about learning health systems and trust and the relation between politics and research. But I can already now tell you that he too did not have the answer. He just said you have to persevere, is that the right word, in trying to find truth and continue doing that, and also leave the discussions about values and what is good or right. Leave that to the politicians and do your job, that you're good at as a researcher. Try to produce evidence of things that you're interested in and that is relevant for society as you look at it. But anyway, I have to start with my presentation, otherwise even this half hour isn't enough. So
like
yeah,
there were before the election,
ciphers.
and there were other times. So
Yeah.
you know what I did? I fired her.
Yeah, I fired her.
You know what?
Yeah.
I did
the right thing. Yeah, and that was that. So learning health systems. A bit of background. Learning health systems, this is a definition from the US Institute of Medicine that was published in 2010. Healthcare system in which knowledge is a natural byproduct, it says here, but I think it's not a byproduct anymore. It is a product, and it is a very necessary product as well. Necessary natural product of the care experience, and to refine and deliver the best practices for continuous improvement in health and healthcare. And health and improvement means not only better care in hospitals and in GP practices and everywhere. It is also dealing with the limitations of our healthcare system. Better care is not necessarily really better care, but it is the best care that we can provide, given the limitations that we have in society. Well, this is the same. Another guy took charge of the labor. Oh, this is another example that I wanted to give. The Vlinder Stichting, the Butterfly Foundation, found evidence of pesticides, huge amounts of pesticides in a field somewhere in the Netherlands. And there was this interest group from Agri, I wrote it down, Agri-Facts, that challenged the results of this study, and also started threatening the researcher who did the research. And the result was that they withdrew the report, and well, I don't know what will happen next, but this is another example of political pressure on research that I wanted to share with you. And this one, this is from my own experience, I'm afraid I have to say. We did a study on vaccinations for COVID and mortality that was hugely challenged by this guy, Maurice de Hond, who said the results of this study could not be right because there was something wrong with the data. And what exactly was wrong with the data never became clear. And we had discussions with him, and at first, well, he did have a point at first, and we changed things, we did minor changes in the report, but it wasn't enough for him, and he continued challenging the results that we presented, and we spent quite a lot of time. Well, trying to listen at first, listen and have a discussion with him about the results. But in the end, we decided, well, this is not going anywhere that we can learn from. Yeah, well, then the discussion died. Actually, it's well, there's no discussion anymore in his website anymore. So this is a bit of my own experience, which was not very pleasant, I have to say, with, well, the relation between politics and research. And this one is also, I found very, very spot on. A quote from political science expert Aleid Damstra in NRC in March 2025. And no matter how strong the scientific consensus is, online there are always alternative viewpoints to be found that claim things are different. These make clever use of the fact that scientific knowledge is never complete, and this uncertainty that is inherent to scientific research then becomes a convenient hook for doubt. And well, that is an introduction that I wanted to give on the topic of trust and the importance of trust in learning health systems. Back to the learning health systems, what is it? Well, a very simple graph here where it goes from practice, and that can be any kind of practice, can also be political practice, healthcare practice, hospitals, GPs, etc., but also political, leads to data. Data is generated in the everyday working of health services, and that leads to knowledge, and that again leads to well, implementation in practice if we do the right things. So there are several issues in this graph that I wanted to mention. Does it work? Yeah. So from practice to data, you have the data quality, you have the fitness for purpose, as I prefer to call it, privacy measures, legislation, data governance, and its administrative burdens. These are issues that play a role in this arrow from practice to data. When you look at the data to knowledge arrow, you're looking at quality indicators, health policy research, health services research, etc. And then, very important also, is the knowledge to practice arrow, where it is about implementation and actually learning from what the data tells us and what the knowledge represents. This slide I included just to illustrate again that it is about loops of knowledge, as you see in this graph, where you have an interaction system that leads to outcomes and which functions within an environment. And in a truly learning health system, we have feedback loops between the interaction system, the environment, and the outcomes. As we see, this is in the middle, it's the provision of care. The outcomes are health and healthcare utilization, and these, the clinical guidelines, reimbursement systems, and Ministry of Health, things that, well, that shape the context in which healthcare is functioning. Just to illustrate that it is not just about this interaction system where the provision of care takes place, it is also about the environment. If you want to ask things in between, please feel free. I rather have discussions underway rather than taking everything at the end. So if you feel like it, please raise your hand and ask questions. So as I said, it's all about trust, and there are 4 sorts of trust, or absent, also if you call no trust also trust, blind trust, distrust. But what we have to think about is smart trust. What is smart trust? What are the pillars of smart trust? And that's going to be the rest of my presentation. This graph comes from Stephen Covey's book, The Speed of Trust, and I recommend you to read that book. It's very interesting because it is it can help us define trust and take the right measures to promote trust. Well, I've been thinking about trust and learning health systems a lot, and what I came up with at the end is that there are sort of 5 pillars of trust. It all depends on the grouping that you do. There may be also 16 pillars of trust, but well, I thought 5 is a good number for this. So pillar 1 serve the public interest, do the right things, contribute to better healthcare and better health, with a joint vision and goal and focus and a common view on reality. That's the very basis. This is the why of learning health systems, and you have to invest in that in order to make it work. But whose right thing? That wasn't me, was it? Whose right thing? This guy's right thing? You know, I did the right thing. Yeah. And whose interest? You remember Ronald Plasterk, who took data from a university and developed algorithms that he made a lot of money with. What about primary care providers? They could be regarded as private enterprises. Out-of-hours services, dentists, nursing homes, hospitals, software vendors, everybody has interests. So it is perhaps a little bit too easy to just say, do the right things and contribute to the benefit of the public interest. There are different opinions about what is public interest. That is what I wanted to say here. Pillar 2, governance and adherence to the rule of law. Governance, that's about who can do what with which data for which purposes. Adherence to the rule of law, but you can ask, well, whose law? We're going to have a new government. There's going to be other people in that government, other people leading that government. And our system is vulnerable for well, the things that governments want. So how do we deal with that? That's a very, very big question, I think. Transparency, of course, privacy measures. We heard Irit talk about new European legislation about pseudonymization of data, and that pseudonymized data are now can be regarded as non-personal data. But what are the prerequisites for that? What do you have to do in order to make it work like that? That's things that you have to have in a governance document, and you have to have these things implemented. Clear structure of the organization is very, very important in any learning health systems, and a common value system. I already mentioned that. Pillar 3, data, fitness for purpose. Yeah, well, that's a whole chapter in itself. Fitness for purpose rather than quality of the data. Fitness for purpose, the term garbage in, garbage out was mentioned a few times. And I wanted to make a comment on that as well in my presentation. And I wanted to say here that let's not underestimate the value of garbage. And I think that's a very important thing to realize, that we should not wait for the fairer future. We should use the fair present as it is, in a wise way. We have to deal with the limitations that there are, and we have to know the limitations. So I've been in a lot of discussions with healthcare providers who were sitting on a lot of data, saying, no, our data is not good enough. It is garbage, and we want to make it perfect before it can be used. And my answer to that has always been, see what you can do with the data that you have, and work on improvements on the way, rather than sitting there and just waiting for everything to become perfect. I used to say that working with real life data is, you have to love imperfect things, and we all can do that. We can work with imperfect things. We do that all the time with our partners, with our work. It's never perfect. So do the same thing with data, I would say. It has to fit in with the clinical practice procedures, of course. And very, very important is that it has to have added value for the healthcare workers and the patients whose data you use in your learning health system. If that is not the case, you can forget about learning health system, and you can forget about appropriate use of healthcare data, because it is never going to be the data that you really want, because nobody is going to invest in data that they do not benefit from. So you have to work on making people aware of the benefits of using their data. And very, very important here is also invest in the knowledge about data. Data stewardship, it has been mentioned before, is the most important thing when you work with this type of data that we were talking about. And questions were asked before in this meeting were about standardization of metadata. Metadata has been mentioned. And I do believe that metadata is going to make a difference. But I also think that it is very, very important to not only focus on machine-readable metadata, but also invest in knowledge about the origin of the data. Where does it come from? Under which circumstances have data been collected? And what is the influence of that on the fitness for purpose of that data? And that is more than ever can be captured in machine-readable meta information, that I strongly believe. So my research is about the world of humans, behind the world of data. This is a matter of humans and individuals talking with each other, where this data come from. And you have to have deep knowledge about the healthcare system in order to be able to judge whether data from that healthcare system can actually be used for any purpose. So this slide makes that clear again. There can be a reimbursement bias. Things that are reimbursed get recorded. That's a sort of a rule of thumb that you can assume takes a role. For example, the number of people with diabetes increased dramatically once there was a ketenzorg. Wat is het? Programmatische zorg voor mensen met een chronische ziekte. Help me here.
The English translation.
Yes, that's what I was looking for. Most of you speak Dutch. So once there was a special fee for GPs for every individual patient with diabetes, the number of patients with diabetes rose incredibly, which was a good thing, but because many people were there who weren't diagnosed as such, but still had the disease. Another thing, in some countries there's a possibility to get money if you have post-COVID. Well, what will happen with the number of patients with post-COVID if you have, if there is a perspective of money there? So that is what I mean with the reimbursement system bias. Very important also is the fact that 5 minutes, is that health policy affects also the fitness for purpose of data itself. If you have a policy in which population reimbursement takes place, there is very little incentives for doctors to record what actually happens in the practices, except for the management of the patient itself, of course. And so that also affects the fitness for purpose of the data that can be used. Well, there are many other things that I'm not going to mention individually, but this slide, this slide I included just to illustrate again that at the end you have outcomes of a research project, and it starts somewhere here in the delivery of care process. And here you see each and every step in between, and each step represents a source of bias, that can lead to, you may call it garbage, but maybe it's not garbage, it's something that you still can use for research. Pillar 4, active engagement. Well, I don't have to discuss this with you. This is very obvious, I think. In order to make this learning health system work, you need active engagement in order to get the data to be used also in the practices themselves. And there's an interaction between the arrow in the beginning that I showed, the arrow from knowledge to practice. If that is not working, there's also going to be problems getting the data, because the people who are recording things will only do so if they feel they benefit from it, or that that they benefit from it themselves or others in their organization, for example. Well, this is an example that I was in the COVID period. During the COVID pandemic, why was it so difficult to get individual level data from nursing home organizations? Anyone in the room? What do you think? We really, really did our best to get that data. They were afraid of negative publicity about their organizations. And so that stands in the way of a learning health system, and we really have to deal with that. And that is part of the call for action in terms of trust that I wanted to make here. Pillar 5, well, that's what I just said. If you don't take care of the last arrow from knowledge to practice, it will work out in a negative way in the provision of data in the first arrow. And that is about what I wanted to share with you. Yeah, well, this is the same sort of question that I asked about the nursing home organizations. Why is it difficult to share quality indicators, scores, among healthcare facilities? And we want them to cooperate, but then they need to share data, to share their knowledge about how things work in their organizations in order to learn from it. And all pillars are relevant in all learning health system steps, but in different ways and dependent on the context. And this is the question I started this discussion with. What is the relation between fair and trust? Well, it's a chicken and egg discussion. You have to work on it both ways, I think, in order to solve this. Thank you for your attention.